go ahead and turn these slides over to you.
All right. First of all, Dalton, thanks so much and HealthTree for inviting me today to engage with patients, which I often get an opportunity to do and really enjoy. And what I'm going to do is I'm going to share, and hopefully this works well. I'm going to share my presentation, and then we'll get started. And we've left ample opportunity to ask any questions and go over anything at the end. So Dalton, or someone could just confirm that that looks, you see it appropriately.
Looks good.
Okay, great, great. So my name is John Mascarenhas. I'm coming to you from the Icahn School of Medicine at Mount Sinai in New York City, where I've been here for almost 20 years now, devoted to the translational understanding and development of novel therapies for patients with myeloproliferative neoplasms, which include, of course, ET, PV, and myelofibrosis. And today we're really going to focus on symptoms, which are obviously very important to patients and a therapeutic target to try to alleviate in many of the trials that we do and many of the drugs that we give. So what I've tried to do in today's talk, and I hope it comes across in the way that I meant it, is to acknowledge and validate the symptoms that occur in MPNs, touch upon some of the biology that might drive the symptoms, how we assess symptoms, and then the application most recently in some of the drugs that we're developing, because it's all tied in. And I hope this makes sense to the patient audience. And again, I'm very happy to take any questions when we're done regarding the presentation or symptoms in general. So I'm going to first start off by showing this word plot that is emphasizing the variety of symptoms that can occur across myeloproliferative neoplasm patients, and the size of the symptom also correlates with the frequency of its reporting in patient surveys. So you'll notice, for example, fatigue is probably the biggest one because it's the most commonly reported symptom, often the most highly ranked in terms of burden of symptom across the three classic MPNs. But we know that fatigue obviously doesn't occur in a vacuum. Multiple comorbidities and real, world social and personal issues can induce fatigue. So it's a complex symptom. And all of these symptoms can be somehow intertwined or interrelated in some way. So these symptoms don't occur in isolated areas. They really can compound each other, make things worse. And then, of course, with all of these symptoms can come neuropsychiatric toxicity of depression, mood lability, anxiety. So it's all very tightly wound together, and we recognize that as a field. So much so that there's been a lot of clinical and translational investigation to try to understand why are these symptoms present, what's driving them, and how do we address them effectively. Um, Health-related quality of life is a big research area these days in academics, but also within the MPN field, and it really relates to an amalgam of symptoms that are directly related to the MPN, toxicities that can relate to medications that we're giving either to the MPN or to other comorbidities. Comorbidities themselves can obviously contribute to the symptom burden, and sometimes it's hard to tease out whether a comorbid condition might be driving a certain symptom burden rather than the MPN, or the relative contribution of the MPN versus the comorbid condition. And then actual complications like, for example, clotting in the abdomen, splanchnic vein thrombosis, that can contribute to symptoms, GI-related symptoms that might be distinct from MPN-specific related symptoms. And then having symptoms and the impact of having a chronic and potentially progressive disease obviously causes significant stress to the patient and their family members, and can affect not just the patient directly, but their financial situation and their interpersonal relationships. And then, of course, the healthcare system obviously is complicated and is a hassle, and that contributes to both anxiety and can likely worsen symptoms in many cases. MPNs are not a static monolithic disease. These are a variety of diseases that we lump under one name called myeloproliferative neoplasms. But there is a trajectory that can often be laid out, as I'm showing you here, where in the early time and the early part of the diagnosis, or even pre-diagnosis, we worry about and see frequently vascular complications. Those could be frank clots, like clots in the legs, DVTs, clots in the lungs, pulmonary embolism, heart attacks, strokes, headaches. Headaches and migraines are very common complaints, often preceding the diagnosis of the MPN, sometimes by years, that are thought to be due to microvascular disturbances in blood flow in the brain. So we know that vascular events often typify the early clinical signs and symptoms of the disease. But with that, we also see systemic symptoms, constitutional symptoms. These are fevers, night sweats, weight loss can be associated, fatigue, as I mentioned, bone pain, etc. These can also be part of the presentation and clinical course and don't always align specifically with having a clot or with having abnormal blood counts. And the progressive cytopenias or low blood counts that we see can often exacerbate symptoms. And then in the increase in spleen or liver size due to extramedullary hematopoiesis, which is when stem cells from the bone marrow inappropriately traffic to these other sites, these other organs, and start creating blood cells in those organs, you get enlargement, and that can cause additional symptoms and signs of the disease. And then there is a risk, albeit it is low, but it is there, of ultimately these diseases progressing or evolving into an acute leukemia. And that's obviously an anxiety both held by the patient and a concern by the treating physician, to monitor for that potential complication, and avoid exacerbators, things that could even increase that risk over the lifetime of the patient. Here is a diagram, and I have to point out that a bunch of these slides were borrowed from Ruben Mesa, who's a close colleague and friend of mine for quite some time, who's really been at the forefront of trying to tease out and understand symptoms. So I have to give him a lot of credit for a lot of these slides and a lot of the work that's been done in this area that complements ongoing work by many groups. And you'll see at the top of this figure of an MPN patient is fatigue. Fatigue is probably the most bothersome, complex, and often refractory symptom to a lot of the therapies that we give. But you can see that the symptoms really are diverse. Inactivity can be tied into fatigue. Dizziness is a neurologic complaint. Night sweats are a systemic cytokine-driven symptom. Fevers can also be cytokine-driven. Cough can be due to many different things, including irritation of the diaphragm from the spleen if it's enlarged, or from pulmonary hypertension, or lung infections. Weight loss can be for many reasons, including cytokines, the inflammation that's associated with the disease, or an enlarging spleen that causes reduction in ability to eat. Or anxiety and depression can lead to low appetite and weight loss. And this can all contribute to and exacerbate mood, and depression. And these symptoms, again, I just want to point out, don't all have to exist in a given person. You can have one or more symptoms, but they're often interrelated and can work to contribute to poor quality of life. So this is a slide that we often show that generally and simply tries to um, tie in aspects of the disease with features of the disease. So, for example, vascular events, which are more common in PV and ET than myelofibrosis, often are tied into the blood counts, an uncontrolled hematocrit, for example, in polycythemia vera. Cytopenias, which are more frequent in myelofibrosis, can lead to, are tied into anemia and the need for transfusions in some patients. That can contribute to fatigue and shortness of breath. Splenomegaly is more common in myelofibrosis than ET and PV. That's an enlarged spleen that can push on the stomach. Sometimes that can cause frank pain. Sometimes it can cause early satiety or filling up easily. That can also disfigure patients. Patients aren't able to wear pants as normally as they will. Sometimes patients will resort to suspenders or certain, wardrobes to adjust for having a big spleen that distorts the abdomen. So these are things that can affect the patient, both from a laboratory standpoint, from a clinical standpoint, but also from a adaptation standpoint. Adapting to low blood counts and anemia and transfusions might restrict your activity or your travel plans or your engagement or your work activity. Having MPN symptoms, which are complex, can affect a lot of different activities of daily functioning. So the point of the slide is that we understand that there are multiple aspects of the disease that may or may not be more prominent in certain MPN subtypes than others, and can be linked to tangible aspects of the disease process. And what do symptoms tell us about MPN biology? Well, we know that myeloproliferative neoplasms are acquired diseases of the stem cell population, the cells in your bone marrow that give rise to whites, reds, and platelets. And those cells acquire mutations years before the patient is ever diagnosed with the MPN that then induce an advantage in those stem cells to populating the bone marrow and taking over the production of blood cells so that only a very specific activated blood cell from that original stem cell is being made. And those are usually driven by driver mutations, JAK2, MPL, or calreticulin mutation. And with this clonal population of blood cells and this activation of these mutations, you get a signaling pathway called the JAK-STAT signaling pathway inside the cells that governs the expression of a lot of different gene sets, a lot of programs in the cells that are responsible for proliferation of blood cells. That's why it's a myeloproliferative neoplasm, a overproduction of white blood cells. But they also are associated with the production and elaboration of cytokines. And cytokines are signaling molecules that are produced by blood cells that prime patients to fight infection, to heal, to regroup after an insult. They are immune functioning molecules. And when you get sick, for example, from a cold, from a bacterial infection or a viral infection, and you feel unwell, those are the cytokines that your immune system is secreting that makes you feel unwell. Living with an MPN is like being on constant alert, constant infectious alert. You're not infected, but your body is creating a lot of these inflammatory cytokines that make you feel unwell, much like patients can feel unwell if they do have an active infection. And these cytokines can be, and I'll show you, can be directly correlated to even specific symptoms like fevers and night sweats or itching. And they can contribute to a very interesting phenomena, which is they can cross the blood-brain barrier. They can affect brain functioning. So patients will often complain of brain fog or mental slowness or anxiety or depression. And of course, one can also have anxiety or depression by having a chronic and potentially progressive disease. So these things are all very complicated as they can revert back into each other. They can be explained directly from the clonal nature of the disease and the production of cytokines, but often feeling unwell can amplify mood disorders and anxiety and feedback on someone's sense of well-being. I show you this plot just to make a really, I think, important point. This is called a heat map, and this is from the one of the original publications of Jakafi. And at one point, when we first started using Jakafi, it was just called INCB 18424. It was just a compound that Incyte had that was a JAK inhibitor, an oral drug that stopped the signaling pathway briefly in blood cells that were triggered by this JAK2 mutation, but as then we figured out, calreticulin mutation and MPL mutation. And as I pointed out, one of the consequences of having this activated signaling pathway is this inflamed state. It's a very inflammatory state. So when you measure cytokines, and what I'm showing you here are individual patients that were enrolled on one of the early trials, whether they were JAK2 mutated or not, and the heat map shows you changes in cytokines. This is what a baseline cytokine profile would look like in a population of patients that were untreated um, with myelofibrosis. And all that red shows you the anger of those cells that are expressing a ton of different cytokines. Each row, it's not labeled, but each row is a cytokine. So there is significant upregulation of these cytokines. That this is really supposed to be a visualization to impress upon you that the red shows that this is a very inflammatory state across these patients. Some patients more than others, but generally speaking, these patients are inflamed. It's angry and it's red. And what I don't have is the subsequent, I should have added it, is the subsequent diagram that shows reduction in those cytokines when you give a drug like Jakafi. So this was some of the first data that I had ever seen that was really quite poignant, that explained to me that patients with myelofibrosis, but it's true of all MPN patients, but here we're talking about myelofibrosis patients, have an inflamed state. You can measure those cytokines, they're very elevated. And when you give a drug like Jakafi, it reduces those symptoms and those cytokines. And it is because we can understand that cytokines drive a lot of the symptoms, and reducing the cytokines with drugs like Jakafi can reduce those cytokines when measured. It correlates with improvement in symptoms with a drug like Jakafi. This was some of the first data that was ever introduced into the research world that helped us make that association. Subsequent to that, a lot of work was done by colleagues, including Aiello Teferi at Mayo Clinic and Dr. Geyer and Mesa, who were at Arizona at that point, trying to understand from looking at big studies and symptoms and the expression level of cytokines, are there cytokines that tie into aspects of the disease? And the answer is there are. So, for example, IL-1 receptor A, this ties into splenomegaly. You see a higher level of IL-1 with splenomegaly. With symptoms, you can see a higher level of IL-8, ferritin, leptin. The point of this is not to memorize which cytokines associate with which aspects of the disease, but it tells us a very important point, is that cytokines matter. They associate with aspects of the disease, and they are deregulated in patients with myeloproliferative neoplasms. The reason why that becomes important because that gives us a window of opportunity, a target to try to address in order to alleviate aspects of the disease, whether it's symptoms specifically, whether it's splenomegaly, whether it's the threat of disease progression. And I can tell you that each one of these cytokines are looked at in all of the drugs that we now give to see, are we modulating those cytokines? And if they go down, does it associate with clinical responses? Are we tying this in neatly and understanding the disease in a meaningful way? I'm going to take you quickly through some of the symptoms and how we think about it. So here's the most common and worst ranked symptom, fatigue. So there are multiple aspects, biologic aspects that contribute to fatigue. And this is probably incomplete, but having low cortisol levels, having deregulation of your hypothalamus and your adrenal glands, low blood counts, depressed mood, all mediate fatigue and can all be in some form or fashion linked to upregulation of specific cytokines, as I'm showing you here. Again, the point is not to memorize the cytokines. There will be no quiz on this, but it is to understand that we can, at very individual levels of aspects of the disease, we can tie in aspects to these various cytokines that are elaborated by the MPN clonal cells. So it ties in very nicely. The same is true with abdominal symptoms. Abdominal symptoms can be pain, could be something more vague like discomfort or bloating, early satiety. And we can understand that there are different aspects that can cause it. Most prominently splenomegaly, a big spleen. Some people have abdominal vein thrombosis. Some people have high pressures in what's called their portal vein, the main vein that takes nutrients and blood from the gut to the liver. Some patients have cytokine-induced nerve hyperstimulation in the nerves that innervate the gut. Again, all of these can be tied in to some extent to individual cytokines or arrays of cytokines. And then lastly, I'm going to point constitutional symptoms, or what are called systemic symptoms, are protein symptoms that are not specific to myelofibrosis per se, but can be seen throughout multiple different types of malignancies. And these are the fevers, the night sweats, the chills, the weight loss. And we know that these are also complicated by different pathways, but can be associated with different cytokines. So there is a rich understanding, incomplete, but actually quite large at this point, of the relationship between these cytokines, these inflammatory molecules produced by the clone, and various signs and symptoms of the disease, which are also complicated by multiple different mechanisms. Symptoms matter, not just to the patient and their loved ones and to their quality of life, but multiple scoring systems. And here I'm showing you the MIPS 70, which stands for Molecularly Inspired Prognostic Scoring System. And this has shown in multivariable analysis that having constitutional symptoms factors in an independent way on risk to the patient, risk for poor outcomes. So if you look at what makes it into this model, it's having anemia, having a high white count, having a low platelet count. These are blood count issues, blasts, immature cells circulating in the blood, or within the bone marrow, fibrosis or scarring in the bone marrow. Molecularly, not having a calreticulin mutation or having other high molecular mutations or multiple mutations. But the one that stands out that I always found very interesting and still important, despite having all of these blood count, bone marrow, mutational data points that weigh in, is the fact that symptoms, that's a patient-reported subjective aspect of the disease, matter. It factors in not just to how someone feels, but it also is important in prognostication. So these symptoms are important to collect, to understand, and to intervene on. We know that symptoms, and here this is from a publication from well over a decade ago now, looking at the frequency, the prevalence of symptoms. This is color coded by whether patients are ET, PV, myelofibrosis, or in purple, the total group. And what you'll see, and why I want to show this, is that symptoms can be across the disease spectrum. But one thing that's always very prominent and very meaningful is fatigue is the most common in all of these diseases and the most severe in all of these diseases. What is really interesting, and I show this just to show that there is a disconnect. So we did this study with Ruben. This was, at least, I don't know, at least 10 years ago or so. And what we did was we surveyed patients in the US and then providers in the US to ask them what is important in terms of goals of therapy for our MPN patients. This survey that I'm showing you here is specifically for the MF subcohort. But what was totally mind-blowing to me, and I had not really appreciated it, was if you looked at what patients, and this is a cohort of 207 patients, but if you looked at patients, what they ranked as most important was slowing and delaying progression of disease, 42%, versus in blue, what physicians reported as most important at 12%. What physicians thought was most important was addressing symptoms, 53%, where only 7% of patients in this survey reported it. We could probably spend the full hour dissecting this and getting feedback from the patients in this group, whether that is also consistent with their vision or their interpretation of goals of treatment for patient versus the way physicians address their disease. But this was an interesting, I thought, survey showing a disconnect between patients and physicians in what is important. The MPN fatigue project started quite some years ago in 2014. It was a collaborative internet-based study with what was the MPN Forum that was ultimately published by Dr. Sherber and Ruben Mesa and colleagues. And really what it did was it was surveys, multiple different surveys to try to understand the context of what patients are experiencing and how it affects in patient-reported outcome tools like the brief fatigue inventory, the profile of mood and stress, patient health questionnaires. So different validated tools across medicine, including the MPN SAF, a very specific MPN 10 score, and trying to understand what is the burden of symptomatology, in particular fatigue. And the findings I think weren't surprising, but were important to validate that fatigue was obviously very common and had a very significant effect on higher likelihood of depression, on mood disorders, and having higher fatigue levels was tied into higher scores on the MPN SAF. And this did correlate with a higher risk of depression. So the idea that fatigue can affect not just the functionality, but the mood and outlook of patients. And that obviously has an effect on their functioning, their work ability, their social engagement, and their productivity, and their sense of themselves. And here we show very nicely that something that I think we all probably recognize, but actually quantified in a survey, showing that the effects of having an MPN, and again, it's color coded green for MF, red for PV, purple for ET, that show how it affects aspects of life that go beyond the office visit. So, changes in employment, having to leave a job, going on medical or disability leave, reduction in work hours, early retirement, change from full time to part time, or even just taking another job at a lower salary because patients don't feel well enough to do their current job happens in a frequent happens frequently with patients with MPNs. And this is a testament to the fact that living with these chronic diseases, the fatigue that's involved with it, the symptomatology has a very direct and very clear effect on functioning at the level of employment. But we know it also has an effect on social engagement, and even relationships and intimacy. So it's not just work. We know that time matters. And what I'm trying to show you here, and this is supposed to be color coded by where in the lifespan of the disease the patient is in, that with increasing time from yellow to red, you have worsening fatigue levels, worsening inactivity, worsening early satiety, worsening abdominal pain, worsening abdominal discomfort. And that no matter how you look at the patient, whether you study them from a symptom assessment form, what's called the total symptom score, the longer the MPN diagnosis, and it kind of makes sense, the worse the score is. So symptoms progress and worsen with time as the disease progresses and worsens in other features. Men and women are not created equal in the sense that there are differences in how they experience the disease. So, for example, women tend to have lower rates of low platelets, thrombocytopenia, and often have in studies higher symptom scores than men do. And their prominent symptoms are often fatigue, bone pain, abdominal discomfort, and headaches. And of course, this doesn't mean that for any given individual or woman who has an MPN that would be exactly their profile. But generally speaking, there are differences between what men and women experience with disease, not just at the blood count level, but also at the symptom level, which was the point of this slide. And we have to recognize that sex is also a determinant and influence of how patients respond to and feel with these diseases. This is a busy slide, but it's really just to make a point. And the point is that I keep saying that we're focused on symptoms today, but therapies are focused on symptoms. And with different therapies, Jakafi, this is Inrebic, this is Vonjo, these are JAK inhibitors, this is Pegasus or pegylated interferon that we did the trials with, or hydroxyurea as a control arm. We're always looking at how symptoms are affected. The most common tool is a symptom assessment form that has been validated and personalized for MPN patients, specifically for MF patients in some of these studies. That is an amalgam of either 7 or 10 different symptoms that are scored from 0 to 10 in intensity level. And we use these, and regulatory bodies use these to gauge whether medications are addressing the symptoms of patients with, in this case, myelofibrosis. To get a drug approved for myelofibrosis, the FDA, the EMA in Europe as well, but the FDA wants to see that you're actually improving how patients feel, first and foremost. So we use these tools and we use what's called the total symptom score, the calculation from these tools to then demonstrate whether there is that it's made up, but a 50% reduction in TSS. So we look at the percentage of patients that achieve a 50% reduction by these total symptom scores as a measure of success, that the drug is having a beneficial effect on that patient. The one thing I will caution patients, if anyone is looking at this and saying, oh, wow, well, Jakafi has a higher TSS 50 than fedratinib or pacritinib, the reason why you see these differences and the reason why it's always dangerous to compare across clinical trials is that the types of patients that went on these trials are different. So the expectations and the history of the patients can be quite different, which influence the assessment of symptoms and the expectation of response. So be very careful if anyone ever shows you a table like this to draw any conclusions across drugs. That's not really the purpose of this table. It is just to demonstrate that we use symptoms in clinical trials to gauge success and efficacy of the drugs that we are interested in evaluating. That's an important part of that. And this is the symptom assessment form. It's very easy. It can be downloaded, it can be put into an electronic medical record, and it is distilled from lots of different symptoms, but trying to take the ones that can be quantified and used to develop a symptom score. And you can see fatigue is up there. Number one symptom, you rate it, as well as early satiety, abdominal discomfort, inactivity, problems concentrating, night sweats, itching, bone pain, fevers, and then weight loss. And this is not weight loss like I was trying to lose weight purposely. This is unintentional. I'm losing weight and muscle mass along the way. This is what we call the NCCN guideline page for the management of patients with, and here I'm showing lower risk myelofibrosis. So this would be patients who don't score high on one of those risk scores. So they may not have a high white count or a low hemoglobin or even a mutation that's adverse. But you can still have symptoms, and that is what I'm trying to draw out here. Even low-risk patients with myelofibrosis, even low-risk patients with essential thrombocythemia or polycythemia vera can still be symptomatic. And the guidelines reflect that understanding and that appreciation. And you can see it bifurcates. If you're asymptomatic, well, you can be watched. Maybe you can go on a clinical trial, but you don't necessarily need intervention. But if you're symptomatic, then we think about things like ruxolitinib or Pegasus hydroxyurea. So there are clear implicit understandings that symptoms don't always correlate neatly with extent or severity of disease by these risk scoring systems and are still deserving of intervention and treatment, even when someone is put into a classic risk group like low risk patients. Now, in the remaining time I have, what I thought I would go through are some data sets just to give you a feel of when we are evaluating drugs. In this case, this is the momentum study for momelotinib, which is Ojara, which was a randomized phase 3 study comparing the JAK inhibitor momelotinib to danazol. Danazol is a synthetic male androgen used for probably 30 to 40 years in trying to improve anemia, but it's not really an MF-directed therapy. This was a randomized study comparing the two drugs in patients with myelofibrosis that are symptomatic and have anemia and were previously treated with a JAK inhibitor. So most of these patients had seen ruxolitinib previously and had anemia and symptoms, and they were randomized to either momelotinib or danazol. And I'm showing this because I want you to get a sense of how symptoms are even integrated into clinical trials. So this is the study design. So the patients were found throughout the world. So it was a global study. They had to have a low hemoglobin and they had to have a TSS, a total symptom score above 10, above 10. So they had to be symptomatic and they had to have seen Jakafi or another JAK inhibitor, was typically Jakafi previously, and they were randomized to either the study drug or placebo, or danazol plus placebo. And the whole point here is it's double blinded. The physician doesn't know, the patient doesn't know what they're getting. So that's the cleanest, most objective way of trying to assess sometimes subjective things like symptoms. And the primary endpoint, the first thing that we're looking at in a statistically designed study is Do the symptoms get better at 24 weeks? There's nothing magical about 24 weeks. It's just the study period that tends to be classically used in clinical trials. And the question is, do we improve symptoms? So what does that tell us? That tells us that drug developers that make drugs, regulatory agencies like the FDA that evaluate for approval, all and clinicians and physicians involved in this recognize that symptoms are important and addressing symptoms are important aspects of disease response. It's the first endpoint of this study, a primary endpoint. And then the secondary endpoints are improvements in anemia and reduction in spleen. But this was one of the first studies out there, big studies that highlighted the importance and the prominence of addressing symptoms. And this is called a waterfall plot. You'll see a lot of these if you ever start looking at the data in any of the MPNs, but specifically, this is symptom reduction in myelofibrosis patients treated in blue with Ojara, in gray with danazol. The columns going down are individual patients that had reduction in their symptom score. So that's a good thing. So seeing these down bars mean reduction. This dotted line shows the 50% reduction threshold. So you can see some patients had very significant reduction in their symptom burden with momelotinib. There were patients, however, who didn't. These are the patients I'm highlighting on the right here that their symptoms actually worsened. So not everyone enjoys all the benefit, but that's understood. But you can see if you look at the placebo danazol combination on the right, you can see that there's not as many patients who enjoyed that 50% or greater decline in symptomatology, and perhaps relatively to the greater population, more patients who had worsening symptoms with danazol. If you look at the statistics, the primary endpoint was very positive. So 25% of patients hit the mark of TSS 50 at 24 weeks versus 9.2% with danazol. And this is called a p-value. This gives us the statistical significance. That, I can assure you, is a very statistically significant p-value telling us that that wasn't random, that we saw that was clearly superior with momelotinib treatment versus danazol in terms of hitting better symptom improvement. We saw that spleen responses, this is a waterfall plot now plot showing spleen responses were also better going down these columns in blue with momelotinib versus danazol. So here we see 40% versus 23%, sorry, 40% versus 6% of patients had a reduction of at least 25% volume of their spleen with momelotinib. And transfusion independence. At 24 weeks, a third of the patients with momelotinib or Ojara treatment were transfusion independent versus 20% of patients with danazol. Again, if you look at that p-value, that tells us this comparison was significant. It was significantly non-inferior, meaning that it wasn't looking to beat danazol, but it wanted to show that it was at least as good as danazol. And here it does look like it's probably better than danazol. And here on the right is interesting because this shows us the kinetics of the hemoglobin. This axis here is the level of hemoglobin, and this is weeks on study. You can see the hemoglobin rises pretty quickly within the first couple of weeks on Ojara and stays elevated from this 8 gram per deciliter mean hemoglobin to about 9.5 to 10 over time. And in gray, these are the danazol patients. They don't go up as much, but when they cross over at this 24-week period, you can see the curves meet, meaning that the danazol patients catch up to the Ojara-treated patients once they cross over to the Ojara arm. And lastly, and I apologize if you're an ET and PV patient in the audience. I've just, for time reasons, I've just stuck with the myelofibrosis data. This is an abstract we presented at ASH just in December, showing results from pelabresib, which is an oral BET inhibitor. These are drugs that change the machinery around which genes are expressed and are very known to downregulate these pro-inflammatory signaling pathways. And this is a randomized phase 3 study comparing pelabresib plus Jakafi versus placebo plus Jakafi, double-blinded, so the physician doesn't know, the patient doesn't know, in patients with myelofibrosis that are treatment naive, so they're just starting out treatment. And here we're asking the question, is 2 drugs better than 1 drug? Is Jakafi plus this drug pelabresib, is it better than just Jakafi alone? And that's the purpose of this study. And what we saw very very clearly is if you look at the combination in dark blue, you see deeper spleen responses. So this is the waterfall plot. The gray shows you what you get with just Jakafi alone. The blue shows you how much deeper you can get the spleen response with the addition of pelabresib. So it was very clear that you could get better spleen responses with combination therapy. 65% versus 35% of patients had at least a 35% or greater reduction in their spleen volume. And you can see this p-value is very, very small. That means that's very statistically significantly superior. Now, what about symptoms? So here's where it gets really interesting. So Jakafi is quite good at reducing symptoms in patients with myelofibrosis. But if you look at the bluish line here, you can see that the further improvement in symptoms with the addition of pelabresib was numerically better, but wasn't statistically significant. It just missed statistical significance. So there was a reduction, a mean reduction in the symptom burden from baseline to week 24 of about almost 16 points mean. And then if you look at the Jakafi plus placebo, which means Jakafi alone, it was about a reduction of 14 points. So it's a difference of just shy of 2 points, and that's mean. And that was almost significant, but not totally significant. And that can make or break a drug. Because that didn't hit statistical significance, that was considered not fully positive study. Even though there were clearly more patients enjoying symptom benefit, it wasn't statistically significantly better. No matter how you look at it, this is the TSS 50 rather than the absolute mean change in symptom score. You get numerically better symptom improvement than Jakafi alone with the combination, but the p-value is not statistically significant. If you look at different types of symptoms, these are domains, whether it's spleen fullness, bone pain, pain of the left ribs, abdominal discomfort, itching, night sweats, fatigue. The blue is the combination. You can see that that goes deeper than the gray in each case. You get deeper responses throughout the different domains. It's not driven by one specific symptom improvement. And then if you ask an interesting question, what patients enjoy both spleen and symptom? What proportion of patients? There's basically doubling at 24 weeks. 40% of patients treated with the combination had both spleen and symptom benefit that met the thresholds versus about 20% who got single agent Jakafi. So you double the double responders. So quick and dirty, but just trying to show you that symptoms are factored into clinical trial evaluation. So just to summarize, because I didn't put a summary slide, but just to summarize, we understand that symptoms are part and parcel of the disease. They're complex in nature. They're not always fully driven by the disease. They could be due to other issues, comorbidities or toxicities of medications. We know that in great part, symptoms are driven biologically by cytokines, inflammatory molecules, which are highly elevated and prominent in patients with myeloproliferative neoplasms. And we know that these symptoms are interrelated. We know that we can quantify the symptoms with patient-reported outcome tools that are validated, like the MPN SAF. We know that symptoms aren't just a burden to the patient and their family members, but they're also impactful in terms of survival. I showed you in the MIP70 that they are an independent influence on outcomes of patients, that symptomatology is telling us something about the disease. The biology of the disease is there, but the symptoms are telling us that that is a bad aspect of the disease. Therefore, they are very important in addressing whether it's commercial drugs that are being used or experimental drugs. And I showed you the various trials that have used symptoms to gauge the success of the intervention, whether it's a JAK inhibitor or other therapies. And now the future of MPN clinical development is in documenting with new therapies that they are at least as good as, if not better than, the old therapies or the monotherapies in terms of reducing symptoms and other aspects of the disease. So I hope I've taken you through what I think is a very important but very complicated aspect of myeloproliferative neoplasms that relates to symptoms. That's obviously important to the patient and their caregivers, but is important to physicians and thankfully is important to drug development and regulators in trying to develop pathways and understandings that will lead to better symptom improving intervention. So with that, I will say thanks. I'll conclude, and then I will stop sharing the slides so we can uh, move forward as Dalton dictates.
Yeah, that was fantastic, incredibly informative and very, very thorough. So thank you so much for going through that all. Truly, I learned so much, and I think I speak for everyone in the audience when I say that. I did want to let everyone know that HealthTree will be launching a MPN fatigue survey. I got a notification that we got IRB approval for that in the middle of that presentation, so perfect timing for that. So I'll go ahead and drop that link in there, and I'll send that in the follow-up email. If anyone would like to participate in that survey, it would be greatly appreciated. But now for the Q&A. We've got a couple of minutes. I don't want to hold you too long, Dr. Mascarenhas, so just let me know when you need to go, but we'll see how many of these we can get through. Um, First up, I have a question from Henry. Are you able to speak about how rusfertide may be used in MPNs and can help benefit some symptoms?
Absolutely. So rusfertide is an injectable that's been evaluated in polycythemia vera that is a hepcidin mimetic. So it's basically a protein that regulates iron availability for red cell production. So giving hepcidin in this form reduces iron availability for red cell production. So it reduces the hematocrit in patients with PV and reduces the need for phlebotomies. Phlebotomies can add to iron deficiency, and iron deficiency can also underlie symptoms, mainly fatigue. So the direct answer to that question is there is data from the phase 3 study in patients. These are patients typically that get a lot of phlebotomies. That's probably where the drug is most used, that are not amenable to standard therapies or in adjunct to standard therapies, where giving rusfertide got the patients into a phlebotomy-free state for the most part, and that was tied in with improvements in iron stores and linked to improvements in PV patients and some of the patients with improvement in fatigue.
Okay, awesome. And then similarly, do you have any comments about Bezremi or Ropeg interferon in terms of symptom reduction?
Well, so Ropeg or Besremi is a monopegylated form of interferon alpha 2b. So it's an injection every 2 weeks. It's approved for polycythemia vera. We just showed positive phase 3 study for ET, so I expect the approval to extend. It's being evaluated in pre-fibrotic myelofibrosis and early myelofibrosis, and we know it's anticlonal. We know it directs against the stem cell clone. So it has the potential in some patients to not just control blood counts, but to even reduce markers of disease burden, like the JAK2 mutation level, for example, as a biomarker for disease burden, which can associate with improved outcomes of patients with these diseases. But if you ask specifically what does it do with symptoms, the answer is patients, and we did this analysis actually with Pegasus in our research consortium study, patients who receive interferon that are highly symptomatic often have reduction, improvement in their symptom burden. Patients who receive interferon that have low symptom burden don't always appreciate that improvement in symptomatology. And in any given individual, you have to balance improving and addressing disease-related symptoms and the potential to add therapy-related symptomatology. And sometimes with interferon as a class of agents, one can actually have fatigue related to the drug or even flu-like symptoms. So it's a complex response to a interesting question about what interferon does to symptoms, and it really depends on the subtype of MPN, the symptom burden that the patient has at the onset, and the doses that are being used to treat the patient. So that's a whole conversation I often have in the office to personalize it for the given patient.
Yeah, it's definitely walking a balance there. I wanted to address these are two separate questions I think tie in really well together, but do all of these drugs cause other cancers down the line, or are there any drugs that may not be as toxic?
A great question, and obviously one that we all think about when we're giving any kind of intervention, whether it's a commercially approved drug or a experimental drug. There's really no good data that any of these drugs actually cause cancer in themselves. But I'll caveat that with some observations. One is if you if you think about and look at data sets from MPN patients, there's one finding that always stands out that is important to highlight is that patients with MPNs have a higher rate than an age and sex matched cohort of people in the community that don't have MPNs of developing SPMs. SPM stands for secondary primary malignancies, meaning malignancies outside of the MPN, so that's not leukemia, but it could be skin cancer, it could be renal cell carcinoma, it could be liver cancer. That risk is not high, but it is there and it is higher than what we see in the general public. So there is an inherent risk in patients with MPNs to have other types of cancers. I would say most prominently skin cancer. Now, in some of the studies, particularly with hydroxyurea, we do see that that risk of skin cancer is probably increased further. And if you then follow it with some of the studies like that have been done with Jakafi, it would even suggest maybe higher risks of skin cancer. I think a lot of that is based on the types of patients that go into the studies. Caucasians tend to have more skin cancer, non-melanoma skin cancer, than those that are non-Caucasian. They also age related. They tend to be people who are older in age that are more likely to get skin cancer, and then sun exposure also obviously plays a role. So it's complicated, but there is a risk, inherent risk of certain types of cancers with MPNs, and it can be augmented to some extent, small extent, but a real extent by some of the therapies, including hydroxyurea and maybe even Jakafi, with skin cancer in mind. There's really no data that has ever shown us clearly and obviously that any of these therapies actually accelerate the risk of developing acute leukemia from these MPNs. I just want to stress that. In fact, if anything, there's a good amount of data that some of these drugs can reduce that risk, but it's not associated with leukemia. Um, and and if there's time and interest, I can even go into some of the historical studies and reasons why that exists, but the data that would suggest that that's not true. But that's always a concern, a very valid concern of patients. You know, am I going to develop leukemia? Would the treatments I'm getting potentially push me in that direction? And I think the safest answer and genuine answer is no, that these therapies don't push the disease. The disease has an inherent risk of developing into an acute leukemia, but none of these therapies have been shown to accelerate that risk.
Awesome. All right. And then another two that I'm going to combine here, but they're both regarding cytokines. So first up is other than monitoring symptoms, is there a measure or test that gauges cytokine rates or increases? If so, how often should that test occur? Then another question regarding cytokines is there any way to decrease cytokines with something other than medications?
Yeah, these are wonderful questions. So we can't in the commercial space, when you're seeing a standard of care patient, we don't have the ability to accurately measure and monitor cytokines. It really is an experimental thing that's done in certain laboratories where what's called multiplex. They can read out from blood, from the plasma blood. They can read out lots of different cytokine levels. And I will tell you, it's a dirty business. And what I mean by that is there's so much noise in the background. You can get so many different ups and downs of cytokines depending on when you take the sample, where you take the sample, how it's read, when it's read. So it is really a confusing area. And for many reasons, including the fact that it's not well drawn out, other than in the context of clinical trials, it is not clinically and commercially applicable to the treatment of patients that are not on clinical trials. So we don't really measure cytokines. I would even say I would be worried about people that do try to measure it because the interpretation of them is very complicated. How you interpret the changes in cytokines and what that means in terms of the care of the patient is best left for clinical investigation at this time. That might change over time, but not really relegated to the standard of care management of patients with MPNs. And then how does one reduce cytokines? Well, that's an interesting question. Other than the obvious, so the things that we've talked about, like JAK inhibitors are very good at reducing cytokines. Diet probably plays a role, and there are studies that show it. So, for example, Mediterranean diet, which is a healthy diet of olive oil, more vegetables and fruits, less fried foods and preserved foods, It has been shown across multiple disease types that Mediterranean diet is a heart healthy diet that reduces cardiovascular events and has been shown to be associated with reduction in inflammation. So I do think that diet makes a difference. I think it's the things that moms have been saying to kids for years that is so not sexy to say on a webinar, but it's the three main things that moms always know is you've got to eat a healthy diet. Sleep is super important. We don't sleep well as a society. We have poor sleep quality. Sleep affects daytime factors like cortisol levels, which also influence inflammation. So sleep, diet, and exercise. People who exercise, and there's many interventions, including physical interventions, yoga interventions, reducing stress that also seem to correlate with reductions in cytokines. So there are lifestyle modifications one can do that to some extent can reduce the inflammatory nature of these diseases, reduce the cytokines.
Yeah. Somehow moms always seem to know best.
They do. We should just listen
Um,
to them.
I know. We are at 1:30, so just wanted to let you know in case you need to hop off. We do have some more questions. I
Yeah,
apologize
I'm
if we
happy to
don't
take
get to
some more
everyone's
questions.
question. Awesome. Um, Sorry, I don't see the name here, but as far as criteria for considering including someone being included on a clinical trial, I just wanted to, I'll let you answer this one as well, but I did want everyone to know that HealthTree does offer a clinical trial finder tool. So if you connect your medical records with HealthTree, it helps kind of match potential clinical trials for you because it can be kind of a bear to go through the criteria for all the different trials. So it takes some of that legwork out. So if you are interested in clinical trials, I encourage you to check it out. But do you have any other recommendations for clinical trials?
You mean in terms of pursuing a clinical trial?
Yes, if someone's interested, where should they go? Who should they speak to about it?
So I think there's a couple of different things. In theory, the clinicaltrials.gov website, clinicaltrials.gov, one word, is a resource online that is governed by the government that allows for access to and transparency of clinical trials, what stage they're in, what are the interventions, where they're open. So it is a resource that is meant for everybody, patients and physicians. I will say that I don't always find it the easiest to navigate. I think patients would often agree. So resources like Dalton is saying, where if if they have a resource that is geared to like MPN patients and more patient friendly, that's often and I'll refer patients to HealthTree or to MPN Research Foundation or to what was called Leukemia Lymphoma Society, now called Blood Cancer United. Those types of patient advocacy groups and engagement will often have resources to help introduce clinical trials and options to patients. But probably the best for an individual patient is to see someone who does it. It's that referral to the tertiary cancer center where there's a center of excellence in MPNs that have an array of trials and clinical trials that can talk to you because it has to be really make sense for you. There are a ton of clinical trials, but
Mhm.
which one makes sense for you as a patient based on your clinical features, your disease features, your expectations of what you're trying to accomplish. So there's a lot of different aspects to it. And obviously the right answer always is see someone like me who just does this full time because we can
Mhm.
give you the full breakdown and present you with trial options that actually make sense rather than a dizzying array of overwhelming options.
Absolutely. Always seeing that specialist when possible is wonderful. That is the best resource out there. Um, And then I'm going to combine another two questions here, but is there a way to be able to determine whether spleen enlargement is due to myelofibrosis and not having a chronic clot in the portal vein? And then tagging on to that, how do you address abdominal discomfort, perhaps from spleen enlargement, um, or other symptoms like bowel movement related, vomiting, anything like that? How do you address some of those GI abdominal issues, and kind of parse through what's causing that spleen enlargement?
Well, to tease apart whether spleen enlargement is due to EMH, extramedullary hematopoiesis, so the MPN cells in the spleen making it big, versus congestion from portal hypertension in the setting of a clot, would be an ultrasound, a Doppler ultrasound. Those are ultrasounds that can actually measure flow rates through vessels like the portal vein, the splenic vein, the splanchnic vasculature to make sure that there is no impediment in flow, aka a clot, that could be explaining why a spleen is enlarged. So I think that if there's ever any question about that, the best way to do that is an ultrasound with a Doppler flow readout to make sure that there's no clot in the abdomen. And then if it's an MPN, so if it's I'll break it down. If it's an MPN driven, like EMH driven, the JAK inhibitors are notoriously good for reducing spleens. I mean, that's how they got approved. And for most patients, to most extent, they can alleviate splenomegaly. Now, if you have a clot, often you end up on anticoagulation. That could be Coumadin or Lovenox or what are called direct oral anticoagulants like apixaban or Xarelto, Pradaxa. So those require anticoagulation, but of course it's nuanced. Some patients can't get anticoagulation if their platelets are too low or if they have tendency for bleeding. So it has to really be weighed. There was a really interesting abstract that was presented at our American Society Hematology meeting that showed that MPN patients who have clots in their abdomen have better outcomes, less future clotting and problems if they're put on cytoreductive therapy. And what that means is patients who are treated either with hydroxyurea, interferon if they're ET or PV, Jakafi or Inrebic or Vonjo or momelotinib if they're MF tend to have less clotting in the future than if they're just left off any type of MPN-directed therapy. So you have to treat the MPN, you have to anticoagulate when possible, and you have to monitor the patient in terms of their spleen on exam or their Doppler of the flow of blood in the abdomen.
And then any comments about ways to reduce some of these GI related issues, such as bowel movement issues or vomiting? Perhaps omeprazole is not working. They're already on Celexa. Is there any other things out there that you've recommended to people?
Well, so this is where I would highly encourage if someone has an MPN is having a lot of GI related symptoms that are, recalcitrant to proton pump inhibitors or omeprazole or other aspects, and there's issues with vomiting or, issues with evacuating the bowel. That's probably where I would definitely see a set, like for example, and I'm carefully not trying to be self-serving here, but for example, at Sinai we have a multidisciplinary team where we actually have gastroenterologists, hepatologists, interventional radiologists, pathologists, and hematologists, part of a splanchnic vein thrombosis team that works in a multidisciplinary fashion to try to understand what's going on with a given individual. Sometimes it's related to clots, sometimes it's related to other issues. So having the right GI specialist in place too that understands the complexity and nuances of having an MPN because it could require an endoscopy, a colonoscopy. It could require more innovative or thoughtful approaches to addressing symptoms. And obviously, I'm not, I can't and shouldn't be giving, direct patient, counseling and advice on a program like this. But it really has to be tailored because there are different ways of trying to address different aspects of GI dysfunction in this setting. And it has to really be understood what's mediating those so you can apply the right intervention.
Next up, and we've got a couple people liking this one. Um, do you have any thoughts on red light panels to increase energy and help with blood flow? They know it's not traditional and not science-backed, but they wanted to know if you've heard anything about it.
So that's a really good question. If this audience had met me 20 years ago, when I was younger and more foolish, I was very dogmatic about a lot of things in life. I saw everything as black and white. Either you did it one way or you did it the wrong way. And I've come to realize that that's not true, and that's not how life is, and that's not how medicine is. So, for example, adjunctive therapies, whether it's red light, sauna, whether it is acupuncture, whether it is anything, yoga, meditation. I actually think all of these things do actually help and contribute to improved outcomes in patients, but often aren't sufficient, in themselves in terms
Mm.
of soul therapy. So they really are, should be integrated in a meaningful and thoughtful and intentional way. I have I seen have I seen outcomes with red light therapy? The answer is sort of. Not necessarily, I would say, from blood flow perspective, I've definitely had patients come back and tell me that their itching in particular is far better when they get red light therapy. I've had patients tell me that their spleen feels a lot less burdensome when they've gotten acupuncture. I've had patients tell me that their energy level is much better and their activity level is better when they're on a specific yoga program or meditation program. So I do think all of these things absolutely play a beneficial role. I wish I could say that, there was one specific, intervention that's historic and solves all the problems. I haven't seen that, but I have definitely seen improvements in aspects of patients with various, quote unquote, non-traditional interventions like red light therapy.
Okay. Next up, and I think that this is another common question, but just this individual's asking about MPNs and depression. Um, do you know if there's any antidepressants that should be avoided due to interactions with other um, MPN medications?
So
Additionally, is that something that they should speak with their oncologist about?
Yeah, so this question is a good one because this comes up frequently. So the answer is it depends. So there can be DDIs, drug-drug interactions with certain antidepressants, anti-anxiolytics, antipsychotics that can have interactions with some of the drugs that we give in MPNs, and can sometimes impair functioning of blood cells too. So I definitely would highly suggest that an intervention for depression or anxiety involves a prescriber that is thoughtful and considerate to use a pharmacist to make sure that there's not a drug-drug interaction, A, and B, to understand what are the potential implications of that agent in terms of platelet function or red blood cell production or white blood cell production. So there are sometimes these situations where that might be relevant. So, make sure that your hematologist knows what a psychiatrist might be prescribing, and vice versa. The psychiatrist understands the hematologic aspects of your care too.
Yeah, having a team that really communicates and understands the whole picture is really important. Um, Again, tell me when you need to hop off. I'm just going to keep going, but
Okay.
I don't want to hold you too long. Next up we have, is hydroxyurea still considered a first line of therapy for newly diagnosed PV patients?
It is. I mean, by guidelines, it's still there. Hydrea is a good drug. I don't have any potential or any specific complaint about hydroxyurea. Um, and I would still use it in the right patients. So Hydrea is still a reasonable drug, and it is still considered a first-line therapy. There are other first-line options like interferon alpha 2B, ropeg interferon, or interferon alpha 2A, Pegasus. And we typically relegate ruxolitinib or Jakafi to after a second line, after being on a first line therapy for the most part. So the correct answer, the board question, if asked in a fellowship test, would be yes, it is still considered first line therapy in a newly diagnosed patient. But I'll just emphasize that it's not the only option in a first line patient.
All right. How often can spleen be studied and to see if it's been enlarged or gotten smaller?
Well, usually the patient will tell you in the sense like their complaints when you do a review system, the early satiety, the pressure, the inability to bend over or lay on that side. Those are important aspects of knowing whether your spleen is getting worse or getting better. And then someone who takes a really good exam, who takes the time to lie the patient flat, palpate the spleen. I use a measuring tape to measure the spleen from the rib cage down to the bottom of where it tapers off, and that you don't need anything very fancy to do that. Now, if one were to go a little beyond that, a an ultrasound or a non-contrast CAT scan can give you more volumetric measurement of the spleen. That's how we do it in clinical trials, but often in clinical practice, that's not necessary. You can just do an exam and gauge whether a spleen is getting bigger or smaller with a given therapy.
Next up are there any options out there for um Jakafi and MMB can cause red blood cells to decrease? What are the options for patients who already have red blood cells but high platelets? Is there an alternative therapy there?
So, so Jakafi and Ojara are very similar, actually. They're JAK1/2 inhibitors. They can both be associated with lowering of the hemoglobin and lowering of the platelet count. Um, Momelotinib or Ojara is also, interestingly, it's an ACVR1 inhibitor. So it inhibits another pathway that can sometimes improve hemoglobin. So you tend to see you tend to see better hemoglobins with Ojara than Jakafi. Jakafi is the first, and I would still say probably the best in class JAK inhibitor that we have in terms of it's a very potent spleen and symptom reducing drug. But Mamalata Bojara is gentler on the hemoglobin. So that's one differential. If someone has low hemoglobin to begin with on their JAK inhibitor, there are therapies that we use in combination, like Aranesp or Procrit. Those are erythropoiesis stimulating agents, or luspatercept or Reblozyl off-label as a red cell maturation agent. So there are things that we sometimes add to offset the anemia. But if the question is specifically asking low reds and high platelets, that's a complicated situation because one has to understand what are the other biologic aspects of that disease that might inform treatments, and there are other treatments that can be used. So, and it might require combinations of treatments. The other thing I'll point out is that we should be less afraid of high platelets and more afraid of low platelets. High platelets themselves, and it depends on where you draw the line to say something is high, is not really clearly a risk factor for anything. It's never been shown to be a risk factor for progression of disease, nor is it actually, and ironically, not associated with risk of clotting. And the assumption is, well, you would think, clotting requires platelets to clump together, so high platelets, higher risk of clotting, but it doesn't work that way. There is not actually a clear pattern of clotting risk with high platelets, which is a whole discussion in itself. So again, I think some of these are difficult to answer because it depends on the greater context of the patient, what medications they're on, various aspects. But again, I guess this still translates to my motto that you should see someone who spends a lot of time doing this to sort of get a better, more personal, thought process on your disease.
Yeah. Um, I'm gonna skip ahead to one here because I think it's a really important one. So besides a 0 to 10 score of fatigue as as in the MPN, are there any apps or validated instruments that can help characterize fatigue to help clinicians understand the lived experience?
Well, we are integrating now and looking at other modalities for evaluating fatigue and inactivity. So, for example, smartwatches and steps, counting steps, heart rate, breathing patterns. So there are wearable devices now that capture a lot of data from patients to understand fatigue in a different way, how is functionally and physically affecting patients. There are other patient-reported outcomes like the Brief Fatigue Index, which is invalidated specifically fatigue that can be used to characterize fatigue. Fatigue is frustrating, and I feel that frustration because it's so debilitating and can be very frightening and impactful on someone's life and functionality. So being able to convey it in a meaningful way to your provider is obviously important. And you don't want to be discounted as oh well, everyone is fatigued and you're just old, so you have fatigue. That should never be the response.
Mhm.
And so I mean, actually the advice I would give is that if you're not getting that message across to your physician, you might want to find a different physician rather than a different tool to measure fatigue.
Then we have, are there any risk or anything that can exacerbate the risk of developing leukemia?
Well, there are things that we used to give that we don't give that have been associated with leukemia, like a drug that you'll never find in the US called pipobromin, which is an alkylating agent. That was clearly shown in studies years ago in France and in Europe to be associated with increased risk of leukemia. There was a concern years ago that Hydrea, as a low dose chemotherapy, could also push people into leukemia. But actually, every study that we've done, prospective study and retrospective, doesn't actually support that. It doesn't seem to be associated with leukemia. So so the answer is there are there any things that you can avoid to exacerbate or promote leukemia? I would say it's kind of the obvious one. Again, what moms have been telling kids forever is, don't smoke. We know that smoking is clearly tied into not just lung cancer, but also blood cancers and promotion of progression of disease. Um, and don't live near a like a radioactive area, because that's another aspect. So, the problem is that often people are exposed with good intention to radiation for breast cancer or prostate cancer or chemotherapy for other malignancies. And that can unfortunately also accelerate the way the bone marrow behaves and promote the emergence of blood cancers and leukemia.
Okay. Um, and I do want to start wrapping up just to respect your time, but I did want to let everyone know that I am in the works of planning another Q&A, not with Dr. Mascarenhas, but with another MPN specialist where it'll be just dedicated to Q&A. So I know Q&A is very popular and everyone loves it. Unfortunately, we just sometimes run out of time. So I'm in the works of getting another just hour-long Q&A session on the books. So be on the lookout for that. But I think that this will be a really good one for us to close off on because it kind of harkens back to a message that we've heard quite a bit from you. But this individual is asking if you take on new patients virtually, but I would like to expand it to how do individuals find an MPN specialist and go about having an appointment with MPN specialists such as yourself?
Like, how do you find an MPN specialist?
How do you find one? Do some MPN specialists do virtual appointments
Oh, yeah.
or just how does that process work?
Yeah, so to find one is not that hard in the sense that you can go on Google and do Google searches and find, who in your area. So there are listservs that often will publish like MPN specialists that are basically voted on and validated by other patients. Leukemia Lymphoma Society, the MPN Research Foundation, all have resources to help patients geographically locate like who would be their closest MPN specialist. I do think that a lot of MP, or I don't know how many, but a good proportion probably do telehealth visits, and sometimes they make sense and they're the only option.
Mhm.
I often think that they don't fully capture all of the aspects. There's something about, and maybe because I'm older now, there's something about being in a room with an actual human that I think is missed sometimes with telehealth visits. But I think reaching out to that specialist, might open up an avenue for a telehealth visit because that is a possibility in some cases. And for sometimes it's just like distance and geography. You can only do a telehealth visit, so that's what it will be. But yeah, like for example, in my case, I'm really big on reviewing the bone marrows of patients. I
Mhm.
don't just like to review the report. So I literally request the bone marrow and then actually sit with the pathologist and read the bone marrow. So there are certain things that I think are really key to to providing a really good consult, a consult that's actually worth the effort.
Yeah, awesome. Well, thank you so much for hopping on and joining us today, and for all of the time and staying a little bit extra. We greatly appreciate that. Um, and I look forward to working with you again, and everything that you do for the community is so incredibly appreciated. So thank you, Dr. Mascarenhas.
My pleasure and honor to address the group today. Thanks for having me.
Of course. And before we hop off here, I did just want to let everyone know about a couple upcoming events that HealthTree will be doing here. We've got a busy week, so I only included three upcoming events, but we have plenty more coming up. So on tomorrow, yes, Thursday the 26th, we have Unshaken, Navigating Blood Cancer with Jason Moak. Jason is a CLL patient, and this will be a documentary kind of going through his experience getting that diagnosis and some things that he's done to help him. So if you're interested in a patient story, really great opportunity. Jason will be joining us and taking questions after we watch that. And then next Tuesday, we have Medicare coverage confusion, understanding preferred pharmacies and prior authorization rules. So, always an important topic, especially for those of us here in the US. So, highly recommend that one if Medicare is your insurance plan. And then next Wednesday, we have the energy audit, managing fatigue and sleep and blood cancer care. So this is a really cool webinar that we're going to be doing. This is actually with a PhD who is working with Dr. Mesa to run a study evaluating blood cancer patients and their sleep. Um, the study is still open. So if you are wanting to take part in some research and hear about some of the work that's being done, highly encourage you to check this one out. It's a fascinating study and again, still open. So this is an opportunity to get involved in the research process and really give back to the blood cancer community as a whole. So just wanted to highlight those. Some other things that we do have coming up as well are the community gather events. Some of you may have been in those prior, but these are an opportunity to get together virtually and just meet some other patients and share experiences. So be on the lookout for those if that's something that interests you. We will also have another MPN specific webinar um, currently scheduled for the 26th of next month, I believe. And that one will be talking about progression of MPNs. So always a lot going on around here. So I encourage you to check it out. Um, and thank you all for coming. As a reminder, we do have that quick survey that we ask if you could fill out at the end. It is very helpful for us. And if you have anything that you'd like to discuss with me, please feel free to email me. My email is just Dalton, Dalton, at healthtree.org. I'm always available for the members of this community. So please reach out with any questions that you may have. Thank you all for coming. I greatly appreciate each and every one of you. And I'm going to go ahead and stop the recording here. I will stay on the call for a couple of moments in case anyone has any questions that they'd like to ask me or if they want to see if anyone else is around to chat. I'll have to hop off in a few, but just want to make sure I get that opportunity. But thank you all.